Welcome to the second part of our exciting Keratoconus Symposium. My name is Dr. Stephanie Wu, and I am the founder of Wu University, which is a company that is dedicated to providing an array of educational resources to doctors and students. And it is my absolute pleasure to introduce our speaker for this evening, Dr. Kent Wellish. He graduated from medical school from the University of Arizona, go Wildcats. He is residency trained at the University of Kansas Medical Center, and he completed a cornea, external ocular disease, and refractive surgery fellowship at the Jules Stein Institute. He owns Wellish Vision Institute here in Las Vegas, which has 3 locations. And this is an interesting fact. Dr. Wellish is known for being the first surgeon to perform laser vision correction in Nevada in 1994. That's such a cool accomplishment. Dr. Wellish is also a mentor to many fourth-year optometry students. He's known for being really kind, calm, and compassionate to his patients. And fun fact, Dr. Wellish was actually my mentor during one of my rotations in optometry school. So it's been really fun, just kind of coming full circle, me being a student and him being my mentor. And now, of course, he is still a mentor to me, a good friend, and just such a great resource to the optometrists and the optometry industry. So Dr. Wellish, thank you so much for joining us this evening, and I'm really excited to learn from you tonight. So take it away.
Thank you very much, Dr. Wu. Wonderful introduction, and so gratifying to train the students that we train. And one of the biggest joys I have is just being able to train students, and we give the TPA hours for those that move to Las Vegas and need the hours to get their certification to prescribe. It's one of the highlights of what we do. So thanks again for the opportunity to visit with you all. And because I've been doing cross-linking for almost a decade, there are a lot of important pearls I want to share with you so you can be savvy, and maybe you'll even know more than the surgeon you co-manage with. You never know. So tonight's topic is the co-management of corneal collagen cross-linking. I call it shaping the future because for so many years we've been the victim of not having a great treatment and watching people get worse before our eyes, having to have high drops, scarring, and unfortunately we even see that to be the case even nowadays that we have great treatments. And part of what I was impressed with Dr. Iden's talk last week was when he mentioned about throwing down the gauntlet. We got to get better screening technologies and screening protocols and make it affordable. And we're going to talk about that a little bit later. So tonight is going to review for the primary eye care practitioner, not only the basic, but also the advanced concepts in co-management of corneal collagen cross-linking. You're all going to be pros. I'm going to welcome you into my living room in my office to just watch it from the eyes of a surgeon, how we evaluate the patient, how we treat them during surgery, post-op care from A to Z. You should all be top-notch experts by the time that we're done. And there's a lot of content here, and I'll be happy to answer all questions at the end of the talk. So again, our learning objectives are to review the pre and post-op care for patients with collagen cross-linking, to share the clinical pearls for targeted diagnosis and treatment, including the indications, to review the evaluation by the primary care physician. Also, the role of the OD, role of the consulting surgeon, some case study reviews, opportunity for questions and answers. One thing that comes up is that if you're an OD, if you're fortunate enough to have a topographer in your office, or most people don't have one at this point, but I want to talk on how you could all get one, I believe. But keratoconus versus pseudokeratoconus, I'd say about 20% of the patients referred to me for keratoconus evaluation are from obviously excellent clinicians. Maybe they see scissoring on retinoscopy, maybe they see the unusual, the irregular Ks. But with keratoconus, some of the sine qua nons are you're going to see an elevated posterior cornea, and as well as epithelial thinning over the apex of the cone. With pseudokeratoconus, there is no elevation of the posterior cornea, and you may get epithelial thickening over the apex. In other words, I could show a topography to 10 keratoconus experts, and just on the topography alone, they might say, oh, that's obviously keratoconus. But then when they look a little closer and see that these other subcharacteristics are involved, a lot of times it's really not keratoconus. So this is true keratoconus. This is on an orb scan, and I have a little Las Vegas style arrow pointing to it, and it's pointing to where it says 0.213 millimeters. So basically that's 213 millimeters of posterior corneal elevation. The cutoff for the orb scan is 40, so anything more than 40 is abnormal, and it's not like it's a litmus test where it's either black or white. It's kind of a gestalt. And if somebody is thought to have keratoconus and their elevation is only 10, that's probably not keratoconus because the elevation starts posteriorly. So true keratoconus will have increased posterior elevation, as you can see there. Also, true keratoconus has epithelial thinning over the apex. This is a topography on the left side where there's inferior steepening, and classically you see the thinning of the epithelium. Now, picking up Dr. Iden's talk last week, he mentioned that one of the other hallmarks is greater variability of the epithelial thickening, greater epithelial thickness. You can see on the right, the thicker area is about 67 microns, where 50 to 55 is normal, and then over the apex of the cone, it's only 43. So this is something you see in true keratoconus, epithelial thinning over the apex. Now, it's not practical for ODs to have in your office an orb scan, a pentacam, a epithelial mapping device. That may or may not be practical, but that's something that we have as keratoconus experts, that we're happy to see the patients and kind of ferret out who has true keratoconus, who doesn't. Pseudokeratoconus has a normal posterior elevation of less than 40 microns. On the upper right-hand side, it says DIFF 0.16 in small print, and that person has 16 millimeters of elevation. That's someone who has normal posterior elevation. That's not keratoconus. Keratoconus doesn't just start it starts with posterior elevation. On the bottom right-hand corner, the orb scan shows a thickness of 623 microns. That's a pretty thick cornea. Also, pseudokeratoconus has epithelial thickening over the area of steepening. Based on the topography shown above, you can see, especially in the upper right-hand corner, that looks like the suspicious topography for keratoconus. But when you do the OCT with epithelial mapping, you can see that the apex of the cone actually has epithelial thickening. Sometimes this will be actually a Saltzman's nodule, but most of the time it's clear. You don't even see scarring. But the way I explain it to a patient is a lot of times you'll see staining or dryness there. It's an incomplete blink, things like that. So it's like the early part of a callus. If you're wearing socks and shoes, and your twin brother or sister is wearing sandals, no socks, no shoes, their feet feel fine, but they may have thicker skin over that. And that's what this is. So before collagen cross-linking and Intex came along, we were taught that keratoconus was a progressive condition that could not be treated or halted other than with stopping eye rubbing or allergy drops or glasses or contact lenses. In more advanced cases, when it inevitably got worse, you could do a lamellar graft or a cornea transplant. And these are slides that show the cornea transplant. But invariably, some patients will progress on to a painful condition called high drops, and then they need a cornea transplant. While cornea transplant is the most successful transplant of all of them, there's a saying that we're taught in residency a little bit cynically: surgery leads to more surgery. If you're a surgeon, you love to do surgery, but really in the best interest of the patient, if you can prevent surgery, you'd like to do that. How does surgery lead to more surgery for keratoconus patients historically, if we're not aggressive enough with cross-linking? Well, the cornea transplant is done, and if somebody's in their 20s or 30s or any age, they need chronic steroid eye drops. That leads to cataracts at a younger age. Also, chronic steroid drops lead to glaucoma, steroid response. On the right-hand side, you'll see an Ahmed valve where those little pointers are pointing at. That person needs glaucoma surgery. And when you see these patients who had keratoconus and develop cataracts and glaucoma, need tubes, it just shows you the importance of being very on it from an early standpoint of screening, to being on it that if they need the cross-linking, we do it early on to prevent these kind of things from happening. Here's someone who had to have a repeat cornea transplant from a graft rejection. And then on the next slide on the right, this person had a repeat cornea transplant from infections, because we're on chronic steroids, your surface is compromised and you're more at risk for infections. These things could all be prevented by just screening for and treating keratoconus, progressive keratoconus at an earlier stage. So when you have these things, when you have the cornea transplant, when you have the glaucoma, that's multiple visits to the doctor for the rest of their life. This cartoon sums up what it must feel like to someone who has to go to the doctor the rest of their life. This is a procrastination therapy clinic, and this is the therapist talking to Mr. Swanson, who's coming in for a weekly therapy session. Says, Mr. Swanson, our session ended 15 minutes ago. Will you please leave? He's saying, I know, just give me a minute. He's procrastinating. So that's the multiple visits to the doctor slide. But before cross-linking and Intex, we were taught that's just the way it is. When I took my boards, we have to recertify every 10 years. There wasn't even not even an answer on the test that you could say Intex or keratoconus. The answer was You have keratoconus, you're going to wear contact lens, and when it gets worse, you get a cornea transplant. I was doing Intacts back then already and preventing it, and it was frustrating to have to pass my boards to recertify. The correct answer wasn't even on the test. That's just the way it is. So then came Intacts in 1999, and for the first time, we could stabilize, even partially reverse progressive keratoconus and ectasia. On the right-hand side, you see the before the Intacts. To the far right, you see after Intacts. Very gratifying for the first time to stabilize corneas and even reverse the condition. We at our institute here, we taught the national course in the wet lab for Intacts almost 10 years ago. We have more experience with Intacts and crosslinking than any other practice in Nevada. Crosslinking was developed in 1998, called the Dresden Protocol. Think about that. That was 10 years before the iPhone 1. That's how long it's been around. Doctors in Europe and around the world reported great success in stabilizing progressive keratoconus and ectasia since 1998. There was also reported success in treating infectious keratitis. So there were several FDA studies that were started in 2008. That's when the iPhone 1 came along, and they were completed, but there was no approval. It took a long time for the FDA to approve. So patients had to travel out of town, out of country, while the FDA took their time to review the data. But finally, we led to the promised land. They approved it in 2016. So we've been using it in Las Vegas since 2012 as part of the FDA study. We are one of 90 sites around the country invited to serve as an FDA study site for the Avedro KXL for both cross-linking and corneal ectasia. We are proud that we were one of the with few centers have a very high rate of follow-up. Part of why it took so long to approve is that a lot of people just fell off and didn't have a lot of follow-up. We were very on it, and our data and our successful outcomes were instrumental in the FDA's decision to approve cross-linking here in the US, finally in July of 2016. So some of the lessons we've learned from Intacts and cross-linking, there's just no excuse to watching keratoconus and ectasia worsen when we now have great treatments. What are some of the keys to success? And the popular, cynically, the politicians say just follow the science. And when I say follow the science, what I mean is this. Aside from patient selection of making sure we operate only on those who have true keratoconus and those who are progressing, getting worse, to have the right outcomes, you really got to be aggressive at the diagnosis and treatment of dry eye, meibomian gland disease. You have to master it and get it under great control before the cross-linking. From my experience, it's critical to attaining good outcomes. And the bottom right-hand side shows a slide of a LipiView. LipiView, LipiFlow, and IPL are important parts of this approach, along with the overall assessment and treatment plan that we outlined as a device that we developed called the Dry Eye Passport. So the vast majority of cross-linking patients will never need IPL, they'll never need LipiFlow, or anything more than stage 1 or stage 2 of the DEWS-2 treatments. They'll need artificial tears, lid hygiene, omega-3s, maybe lacrimal plugs, possibly topical cyclosporin. That's probably all they'll need. However, because cross-linking is a corneal procedure, and corneal procedures are known to worsen dry eye in a number of patients, there are a certain percent who have gland troubles, and they may need IPL, they might need LipiFlow, they might need serum tears, amniotic membrane treatment in the future to treat pre-existing before the procedure or resulting dry eye. It's well known that all corneal procedures can cause or worsen dry eye, and it's important to have this education and discussion before the procedure. On the far left, you'll see the normal-looking glands with normal meibomian secretions. It's surprising how many, when you look at the glands and even express them at the slit lamp, they're blocked. And the more you can identify these patients and show them their glands before the procedure, the more they know that it's a pre-existing condition. There's an old saying from our residency training that when a patient has a problem and you didn't do the surgery, it's their problem. But when a patient has a problem and you did do the surgery, now it's your problem. So the more we share with patients pre-existing risk factors, the more we share with them that, hey, your cross-linking is a one and done procedure, but your eyes do have a tendency to be on the dry side. And this is something we're going to help you with the cross-linking, but the taking care of the dry eye is a partnership that we're going to have for the rest of your life. The patient, the surgeon, and the co-managing OD. So these are all important things to emphasize before surgery, because if you don't raise it before surgery and they're slow to heal, they have bad dry eye problems afterwards, you didn't tell them about it, they think that you caused it, they don't realize it. Again, all corneal procedures can cause or worsen dry eye. Better to have that conversation ahead of time. This is something that we developed here that if you want to take a picture with your camera and use it for your own benefit, we call it the Dry Eye Passport. We show this with patients, showing them normal meibomian glands, what blocked glands look like. We show them what the normal glands in the top and then the gland atrophy and severe gland dropout. We do a lip view test on everybody to show them where their glands are so they know in the spectrum where they stand. This is a little fun map we made up where we explain to people that they live in a country called Dry Ireland, and the reason their eyes are dry is mostly because if you think of the globe of the Earth, how it's round, but if the entire terra firma was at the same level, the ocean would cover the entire Earth. Where land is above sea level, it gets dry. Their apex of their cone is above sea level, and that's usually where they find the dry spots. So we explain the gamut of treatments from dry eye, from eye drops to pills that they take, omega-3 vitamins, things they do at home with hot compresses, ointments. These are things that we start people on as appropriate. If people have staining that doesn't get better, we will ultimately do lacrimal plugs on them. And then if they need it in the future, less than 5% will need LipiFlow or IPL, but it's better to find out about it ahead of time. And we also put on the bottom right here, contact lens land. They might need scleral lenses. And on the far right, there's a lot of undiagnosed and underdiagnosed nocturnal leg ophthalmos. So we have a whole little part of it that talks about the right kind of humidifiers and other treatments for nocturnal leg ophthalmos. Even though this seems like a diversion from why they're actually in the office, and even though it's a pain in the neck for the patient and the doctor to have this discussion, too many times, people who treat keratoconus patients with cross-linking don't have this conversation, don't educate the patients, and they have a bad result because it took too long to epithelialize. We also use this other brochure I put together. I just summarized things from the DEWS-2 study, and I call the treatment of dry eye in 4 steps. First step is patient education, using high-quality artificial tears, modifying environmental factors, medication modifying factors, lid hygiene, hot compresses, lacrimal plugs if needed. Step therapy is step 2. Including the plugs, Lefex if it's needed. Over to the far right, there are cyclosporin drops that are often needed in cases that are not getting better without them. On the bottom right, we show the different levels of the tear film, and we're trying to how theirs compares to the ideal. So there's patient education, all the different things we step through with the patient. So even though they're coming in for keratoconus, and even though it does take time to digest, it's important to lay the groundwork of dry eye because it's not a trivial matter. Yes, we live in the dry capital of the world, Las Vegas, but anytime we're talking about cross-linking, you got an epithelial defect that's going to heal, and you want it to heal properly. We even have to let people know that in the future they might need serum tears. They might need scleral lens in the future. They might need the amniotic membrane graft to help with their dry eye. Having this discussion ahead of time kind of puts it all out in the open that this is a team sport. It's not just doing a procedure and recovering. Aggressive dry eye treatment is very important. Again, the bottom left is good meibomian glands. The bottom right, meibomian glands are 25 to 50% dropout. There's on the bottom left here, on the bottom right now, 75 to 90% dropout. We show patients where they are on the spectrum so they just know what to expect ahead of time. All guided by what we call the science, quote unquote, the DEWS-2 study. This is something that we developed ourselves called, I call it the 5-minute fluorescein test. Many cases of dry eye are missed because of delayed corneal staining. In other words, we're all in a hurry. Nobody wants to take 5 or 10 minutes to do a fluorescein stain on a patient. So you put the stain in, it doesn't stain, and they're good to go. And so oftentimes when we think they're ready for surgery, there's no visible staining right after the fluorescein's instilled. But if you just waited 5 minutes to have them close their eyes, look at the bottom, look at the right-hand side here. That same person who we thought had no staining is pretty prominent after 5 minutes. So my personal pearl for you is many cases of clinically significant dry eye are missed unless this test is rigorously performed pre-op. This test is what I would call above and beyond the quote-unquote standard of care. The FDA process and the study did not call for this kind of a test, but in my opinion, failure to perform this test results in delayed epithelialization for 8 to 10% of patients, delayed healing, which then leads to corneal haze and decreased vision. So yes, it's important to do this test. It lets our patients know that cross-linking, it's something more important than just doing their cross-linking. It lets our patients know that by doing this, provided this extra level of care, it lets our patients know that we tell them we've got your back, like this cartoon shows. So in the FDA study, the lessons that we learned were that we thought we were getting great results. Our patients were happy. But when we finally looked at the data, 8 to 10% of patients in the FDA study following the FDA protocol lost 1 or more lines of vision. Many lost 2 or 3 lines of vision. And it's amazing that it got approved by the FDA with such kind of a downside. But the fact of the matter is, very few keratoconus progressed, and the vast majority did the same or better. So in the FDA in vitro study, all the results were good enough to gain approval. I take things personally. If any of my patients has a loss of best corrected vision, what can I do better? We felt that it was an unexpected disappointment. And looking at our data, we saw that this occurred in those with delayed epithelial healing. These patients were not cleared for surgery if they had pre-existing moderate to severe dry eye. So unless we thought they were treated adequately per the FDA protocol, unless there was no staining, they didn't have surgery. So clearly the FDA protocol, which was designed in the year 2008, the iPhone 1, it missed something, and therefore so did we. So shortly after the start of the FDA study in 2012, we were invited to be part of another FDA study for a dry eye treatment that was later came to be known as Xiidra. In the Xiidra study, the protocol required judging the corneal staining immediately after you put the fluorescein in, but then waiting 5 minutes after instilling the fluorescein. Have the patient close their eyes for 5 minutes, come back, and take a look. I thought it was just an eccentric thing to do at first, but on the very first patient, we were surprised how much staining that we would have missed. We were surprised how often patients with little to no staining right after the fluorescein is instilled can develop very significant staining after 5 minutes, even though we had them keep their eyes closed for the 5 minutes. It's easy to see how this undetected staining could lead to delayed epithelial healing and hence corneal haze and decreased best corrected vision. The slide on the bottom here shows the fluorescein stain right after a couple days after the procedure. By day 3 or 4, when you're supposed to be healed, it's not healing. By 4 or 5 days, it's not healing. When it finally heals, you kind of set in motion bad stuff. And on the far right, you can see the corneal haze that can develop. This is exactly what can happen if we're not aggressive beforehand at treating the dry eye. So we theorized that if we added a 5-minute fluorescein test, I just made up the phrase 5-minute fluorescein test, to our pre-op clearance, and if we follow the DEWS-2 study recommendations in order to allow complete corneal healing and lack of corneal staining in the area to be debrided and treated, this could prevent the loss of best corrected vision. Today, after treating over 300 eyes with our protocol, and after also instilling a few other surgical pearls I'll review with you tonight, I developed and adopted these on my observations. We don't have a single patient with any loss of best corrected vision. So if there are 1 or 2 that we don't know about, we're still at less than 1% compared to 8 to 10% losing vision in the FDA trial. Yes, what I'm telling you is off-label, so it can't be in the product labeling. We have more than a few patients who actually gain 1 or more lines of best corrected vision. This is especially gratifying when you consider that we only are treating patients who actually were worsening and unstable prior to their cross-linking. So see people stay the same or even get better, very, very rewarding. So what is cross-linking? Cross-linking is when the cornea is strengthened by the application of riboflavin, vitamin B2, followed by the treatment with the ultraviolet light. Numerous studies have shown that treatment can increase the rigidity of the human corneas by 300% or more. The biomechanical rigidity and biochemical resistance of the cornea is increased through instantaneous formation of covalent bonds, crosslinks, also the inhibition of collagenase. Mechanical rigidity and biochemical resistance of the cornea, long-term stabilizing effect by synthesis of new collagen with different structure and resistance. So the purpose of cross-linking is to halt the progressive corneal ectasia, prevent disease progression through corneal stabilization. Early disease, we prevent the necessity for rigid contact lens wear. They only have to wear glasses. In moderate disease, with rigid lens wear, it stabilizes the cornea to prevent the need for a cornea transplant. Patient selection, unstable keratoconus. Insurance companies won't cover it unless it's unstable, and the FDA labeling says you really should. It's really meant for people who are unstable, not people who are stable. So in general, the FDA approval is for 14 years or older with the ability to cooperate during the treatment. We've treated patients as young as 10 years old off-label. These are kids that really did not look good. Their cone was rapidly advancing. They were as young as 10, and surprisingly, they cooperated fairly well and got through it all. So again, patient selection is keratoconus with progressive ectasia, also increase in spherical and or cylindrical component of the refraction. Part of patient selection is topography, showing alteration in corneal shape and disease progression, significant corneal scarring and or inability to wear contacts to provide reasonable vision or indications patient cannot be successfully rehabilitated with cross-linking alone. If their cornea is too advanced in their worsening to be fit with a contact lens does not reverse the steepness nearly as well as intacts. Some of those patients are better off with intacts and then do cross-linking. This is a referral form. My point to you in showing you this is that when you refer patients, you make the patient's life easier and the surgeons and yours by trying to include any kind of historic and current refraction. Most of the time, we don't really get the history, and then if the insurance company is scrutinizing things and we don't have a definite evidence that the refraction is worsening, the keratoconus is worsening, the astigmatism is worsening, then they deny payment, they deny authorization. So the more you can include history to show the worsening, whether it's Ks, topography, refractions, anything you have is very helpful, because otherwise it results in delays of getting the insurance companies to approve it. For part of the evaluation that we do for our treatment is, we recommend that topography is done with a contact lens left out 2 weeks prior. Again, if people are living in their contact lens so they can't function, we're not going to be hardcore about it. We want to be realistic, but we try to recommend if we can. Also, we take K readings, manifest refraction with the best corrected vision. For pachymetry, you want the pachymetry to be greater than or equal to 400 microns at the time of the surgery. That's after you remove the epithelial cells. We are able to increase the thickness during surgery with hypotonic riboflavin drops and or using a scleral contact lens as a standoff. So again, please send the refraction and best corrected vision with glasses, any historical refractions in case, and information with the referral form. We also perform a comprehensive eye evaluation. Again, contraindications less than 400 microns with some exceptions. Other contraindication is prior herpetic infection, current infection, history of poor epithelial wound healing, or severe ocular surface disease. Of course, autoimmune disorders are contraindication, as well as significant corneal scarring. Just today, we had 2 patients that had mild to moderate corneal scarring. I've treated dozens and dozens. They've all done fine. Is that you'd rather get to them before they get to that point. Other contraindications is if you can't fit a contact lens or scleral lens, rigid or scleral, because the cornea shape is that bad, that might be a reason to do intacs before you do the cross-linking. Severe dry eye is a contraindication, as well as unrealistic expectations. Unfortunately, there are those in our profession that falsely mislead the public to think that once they have their intacs or cross-linking, they'll never need glasses again. That's just not true. And so realistic expectations are very important. I'm a believer in the phrase proper preparation prevents poor performance. So we identify and treat dry eye pre-op to the point of no staining at all in the treated area on a 5-minute fluorescein test. Also important is no vitamin C from 1 week pre-op until 1 day post-op. That means not only not even taking the pill vitamin C, it means that we give a printout of common foods ranging from lettuce, tomato, most fruits or vegetables, even omega-3 vitamins have vitamin C in it, nothing like that at all from a week before the procedure till the day post-op. The reason for that is vitamin C is really good at protecting patients from UV penetration, but we want the UV to penetrate into the cornea because that's what causes the cross-linking. Patient also needs to be advised ahead of time to prepare to miss work, stay home in a clean environment for 4 to 7 days post-op to avoid the delay in epithelial healing. Beware of problem patients who might not be compliant. This is an actual patient that my text wrote on the little sticky note for me. Dr. Wellish, patient likes to lick her fingers and discuss her dead dog. Very condescending. You don't know what to think about this. The patient wants to have their surgery right away. You're depending on the patient being compliant, and you really got to try to size up. Am I opening Pandora's box here? When that kind of thing happens, you wonder if God's at his computer just having fun. The guy's walking in front of a building, a piano is crashing on top of him. Was that a coincidence, or was God just having a little fun at his computer? Sometimes you don't know. As far as treatment is concerned, we try to assess and decide the treatment based on the severity. If it's mild to moderate keratoconus and they're contact lens tolerant, yes, we can do cross-linking. That's 95+% of the time. If it's moderate or severe keratoconus and contact lens intolerant, maybe you have to do intacs first or combine them. Patient education and informed consent is all part of the treatment process. On the day of the procedure, we remove the corneal epithelium, we saturate the cornea with riboflavin, and then we do the UV treatment. Then we do the post-op meds and bandage lens. What I'm going to tell you now is that the FDA labeling in the protocol was 9 millimeters of epithelial removal, 9 millimeter diameter. What I'm doing now is more the base of the cone. I'll show you the reasons and show you why, but this is called off-label. This is step 1 in the procedure where we remove the corneal epithelium. Underneath the microscope, we're just wiping off the epithelium. And this shows you the OCT packs, how most people have thinner part of their cornea in the center of their cornea. Very common with keratoconus, obviously, is a decentered part of their thinning. So this person, their thinnest spot is 453. And if you look at that corneal map of the OCT, there's the green area and then there's the lighter yellow area. And I want to call that green area the base of the cone. So when I'm doing my procedures, I look at the base of the cone and you have to ask yourself, do you want to remove the entire almost limbus to limbus and have that much to heal? Or do you want to remove a smaller amount? My feeling is if somebody's got 666 microns of corneal tissue in the mid-periphery and 658 down in the inferior part, that part is not the part that's the problem. The part of the problem is the base of the cone. So in order to have faster epithelial healing, personally, I debride just the base of the cone, identify that. So this is somebody who has the same OCT packs, and this is the FDA study, and the labeling of the FDA says the protocol is to remove 9 millimeters. You see the area in red, that's if we removed all 9 millimeters, that's a very large epithelial defect to heal. And what happens? If it's slow to heal, the haze that's going to develop is right in the center of the cornea. And so the haze is going to affect the vision. So as an alternative to that, what I do is I identify the base of the cone, and I see that little smaller red area there. By doing that, it's eccentric because it matches the base of the cone. It's a smaller area, so it heals faster. And where that little asterisk is the center of the debridement. If there's a little bit of haze there outside the pupil, that's not going to affect their vision. So this is what it looks like on the left, the OCT pack, and on the right shows a matching debridement of the epithelium. You can see it's not limbus to limits, it's not 9 millimeters, it's over the base of the cone. And you can see here, I kind of superimposed, here's the epithelial defect when we make it, and that little red dot is my guesstimation of the center of the epithelial debridement area. So if there's a little bit of haze right there, that's not going to interfere with the vision nearly as much as if it was in the center of the pupil. So that's part of our secret sauce of getting better results. Next step is we saturate the cornea with riboflavin. The in vitro system has a timer on it where it goes ding every 2 minutes, so you know when to put the riboflavin on. It's a viscous gel that has dextrate in it, so it stays nice and thick and gooey, keeping the cornea nice and moist during the procedure. Next step is after you've saturated the cornea, you check to make sure there's flare. The flare is a yellow dye showing inside the anterior chamber. Next, you center the UV light. There's little beams on there, little spokes that you can center right on the cornea and know when your X and Y and up and down are just right. Next comes the UV treatment. That's the UV light. See how it glows like that? And there's a little timer on the upper right. That timer shows the treatment in progress, how much time has gone by to track it for you. Shows the treatment in progress. Half an hour, we play music for the patients, whatever they want to listen to. When we're done, we apply the antibiotic and nonsteroidal drops. Then we apply a bandaged contact lens for comfort. Sterile technique. Then we take off the drapes, examine the slit lamp immediately post-op. Make sure the contact lens is fitting properly. Make sure there's nothing underneath it. Now comes the discharge instructions. This is pretty much similar to PRK. We use a mild steroid drop, like FML is the least expensive, but Flarex, Lotamax, or Neltus work a little bit better. But if price is an issue, if their insurance doesn't cover it that great, FML is fine. We go 4 times a day for a month and 3 times a day for a month, etc. Taper month by month. We also big believers in using a 4th generation fluoroquinolone, moxifloxacin. I don't like Bezavance in this scenario because it seems to interfere with epithelialization. We go every 2 hours for the first day just to make sure they don't get an infection, then TID until they're reepithelialized. As far as a nonsteroidal anti-inflammatory, personally, I like to use Prolenza instead of ketorolac because ketorolac can delay epithelial healing and can even cause a corneal melt. So I'd rather give them a sample of Prolenza than have to worry about having a poor result. They do it once a day until either they're epithelialized or until they're comfortable following the procedure. As far as pain prevention, we tell them to use refrigerated, non-preserved artificial tears every 30 to 60 minutes for 1 day, and then as needed for the next 3 to 4 days. Also, to prevent pain, we tell them to use a frozen bag of corn or peas or something similar over the closed eyelids under their goggles. They can also use over-the-counter Tylenol or oral non-steroidal anti-inflammatory or a combination together every 6 hours as needed. We used to prescribe hydrocodone as needed for pain, but then with increasing opioid abuse protocols, it's so onerous, the bureaucracy you have to do, that we now just say, take the painkillers, they're more effective than anything else. If that's not enough, go to the drugstore, get some Benadryl, sleep it off, and then restart your pain meds in another 6 hours. So far, that's worked fine. We also emphasize the importance of 100% UV protection for the first 6 months post-op, frequent use of preservative-free artificial tears. Patients are educated to avoid exposure to sunlight for a minimum of 24 hours. If riboflavin is still evident during the 1-day post-op, you see that through a yellow tinged corneal tissue, then continue UV protection. Patients are instructed to be out of their contact lenses for their usual ones for 2 weeks post-op, and it's okay to have vitamin C in food starting at 1 day post-op. So you can see the recovery is very similar to PRK. Topical NSAIDs and prescriptive oral pain meds are important for patient comfort. For post-op care, day 1, we do a check of vision, slit lamp exam to make sure there's no infection, make sure the contact lens is okay. The 3 to 5 days post-op, check the vision, slit lamp exam, take out the contact if they're epithelialized. If they are not epithelialized, we consider an amniotic membrane tissue. At the 1 month post-op, we check the vision. We do an auto-refract. There's no sense splitting hairs on a true refraction, too time consuming, not really going to accomplish much. Check the pressure at that time, slit lamp exam. Here's what we do, a topography. We expect a temporary increase in corneal steepening at 1 month and decreased best corrected vision at 1 month due to how the corneal heals post-op. The earliest time to be fit with new contact lenses or glasses would be after the 1 month visit. You may want to wait till 3 months because the cornea continues to fluctuate a lot between 1 and 3 months. After 1 to 6 months post-op, the cornea starts to flatten as the epithelial layer becomes more compact. So again, if their best corrected vision or their vision in general is worse in the first 1, 2, or 3 months, we want to tell them that ahead of time to expect that. And if there's steepening in the first 1 to 3 months or more, we expect that too, not to freak out, because sure as time goes on, it flattens out, becomes more flat after 6 months. So post-operative care, the 3 month visit, visual acuity, auto-refract, IOP, slit lamp exam, topography. At the 6 month exam, check the vision, auto-refract, refraction, a real one at that point, IOP, slit lamp exam, and topography. 12 month exam, visual acuity, uncorrected, auto-refract, true refraction, IOP check, slit lamp exam, topography, including a Kmax. In the FDA study, they first looked at Kmax at month 3 and month 6. They just found it was too unreliable because of all the variable healing. So it's really meaningless until the 12-month period. Additional treatment cross-linking may be considered if there's continued progression, if it's evident on topography. So far, in over 300 cases, we've had 0 progress. Studies show that previous cross-linking does not reduce the effectiveness of follow-up procedures. As far as healing is concerned, the maximum keratometry and visual acuity is typically worsened at 1 month, followed by improvement and stabilization after 3 to 6 months. There's an initial epithelial thinning and stromal edema and keratocyte apoptosis on confocal microscopy, and that explains the initial worsening in the first 4 to 6 weeks. There's improvement after 3 months due to epithelial thickening, decreased edema, and collagen compaction. And now I'll talk about what's called the demarcation line. The demarcation line is not visible in the first 2 to 4 weeks, but if you go to B, the demarcation line you can see on slit lamp, it lies at a depth of about 300 microns. It has a conical shape. The reason for that is that it goes from the surface of the cornea down to 300 microns, and it's explained by the increasing thickness of the cornea in the periphery. So the best way to see it is with thin beam, high illumination. You can see it looks like a little bit of haze, but what happens is, if you look in the central cornea, it can be seen at approximately 60% depth, because 300 microns out of a 500 micron cornea roughly is 60% depth. But in the periphery, demarcation lies at about 30 to 40% depth. It goes just as deep, but the cornea is thicker in the periphery. So there's more untreated tissue peripherally. So what you see as haze is actually within normal limits. You want to see a demarcation line. It lets you know the treatment is working. And again, in my experience, using the treatment methods that I've described earlier, it has not resulted in a decreased best corrected vision. So there's an increased risk of complications if the pre-op best corrected vision is better than 20/25, if there's high pre-op K readings, if there's underdetected, undertreated pre-existing dry eye, MGD, if there's a delayed healing of epithelial defect. If you combine it with PRK, you get more haze. If patients return to work or miss their appointments or just don't follow instructions, it can lead to an infection if they're not careful. Other potential complications are delayed corneal reepithelialization, corneal haze, inflammation, infection, increased IOP from steroid response, as well as endothelial issues, and treatment may fail to stabilize the cornea. In conclusion, we all waited many years of waiting for the FDA to approve cross-linking. Now that it's been approved and been available for the past 5 years, there's really no excuse to delay diagnosis and go on to treatment. We thank Avedro for bringing this technology to the US and making it available to all of our patients. And we thank all of you for attending tonight. We're all officially Coneheads tonight. If you have any questions regarding any treatment that you want to ask me offline, take a picture of this slide. I'm always available through text messages, through my cell phone, or through emails. this is one of the most proud, rewarding part of my practice, because for years and years and years, watching people get worse, have high drops, needing cornea transplants, now finally being able to do something about it is very, very rewarding. So thank you all for attending tonight.
And thanks again, Dr. Wellish, for your time and sharing all of your insights. And thank you, everybody, for joining us. See you next time.
Thank you all. Wonderful being together tonight. Thank you, everybody, for attending. Really enjoyed it. Thanks.